Good afternoon, everyone. So I am Scott Ege, a physical therapist practicing in the Northern Illinois, Rockford area, kind of Rockford, Chicago market. And I'm excited to be here. What a privilege it is to be able to present today and just share some insight and information that I've learned over the years around proving value to employers of the services that we provide as physical therapists and doing work on site with employers. This particular presentation focuses more on the total worker health model, and that's what I'm using as my OHP capstone presentation. So let's get started. Just out of and I've got a lot of slides. I'm going to apologize ahead of time, but I'm going to move pretty quickly through the first bunch of slides so that I can get to the value equation that I think is the meat of this presentation. But I am going to describe my role as a consultant in providing early intervention or EI types of programs for employers that improve the total worker health of an employer's workforce. Going to describe a little bit about early intervention programs as a strategy for reducing sprain and strain soft tissue injuries, as well as what I think is promoting the overall musculoskeletal health of a workforce. And then also just emphasize as entry point practitioners, we as occupational health practitioners need to utilize processes that not only effectively manage the early intervention cases, but also demonstrate and prove results that can be meaningful to the employer. So I'm going to provide some guidance in this around key data elements that we use, capture within our early intervention encounters, and then generate metrics and reports that demonstrate value to the employers. And I think the key to all of this, and I'm sure we're going to hear this with all these presentations, the goal that I see is to keep workers on the job healthy, happy, and pain-free. And that's really what this is all about. There's a whole lot of stuff up here on this slide about my career path. I've been doing this for a long time. Started working with employers not even a year after I was first out of PT school back in the early 90s. I've had a significant number of people mentor me in that process. I want to mention Dennis and Sue Eisenhagen and Ginny Halling. They were instrumental for me early in my career and inspiring me and encouraging me, moving me forward. And then I also want to mention Drew Boston, Kurt DeWeese, and Debbie Reed, who we worked together to work with OSHA back in 2015 all the way to 2019 to actually get clarity around some of the letters of interpretation and how OSHA looks at the use of first aid interventions. So I want to mention those folks as well, and all this other stuff on the screen just means I've been around this sandbox for a while. These are a whole bunch of companies that I've had the privilege of working with over the years in my career in occupational health and musculoskeletal health. And this is just a menu of services that our company provides. We like to identify ourselves as experts in musculoskeletal health and movement. And I'm going to be specifically presenting on early intervention today, but there's a list of other types of services that we provide as well to the clients that we serve. I wanted to talk briefly about just Illinois State as far as direct access, kind of get in. I don't want to get into the weeds on all of this stuff, but Illinois allows unrestricted access to physical therapy services for fitness and wellness needs, which is where EI kind of falls under that umbrella. We do have direct access. We are not providing on-site formal physical therapy treatment at many of the sites. I think there's an opportunity for that. But where our Practice Act comes into place is really more around the fitness and wellness needs. And then this also aligns itself nicely with the position statements for PTs as entry point practitioners that have been adopted again through the APTA and the direct to employer physical therapy services. I mentioned that this is under the umbrella of the total worker health model, which essentially is not only just focusing on health and safety, what we would call just the general stuff of health and safety at an employer at the facility, but it's the health and safety of the workers when they're not there. And when they are there, how are we promoting not just ergonomics and movement and safe motion, reduce injuries, all of those things, but what are we doing also to try to help improve the overall health of the worker? And our focus in particular, I mentioned, is musculoskeletal health. So this is a broader approach. It's not just, as I see, early intervention, feeding, preventing OSHA recordable injuries, those types of things, but it's actually promoting an overall healthy workforce. I think this also speaks to a little different aspect. You know, there was a landmark study or a report that came out for physical therapy services, direct to employer services, that the APTA shared and put out. I've got it mentioned up here and references in the material, but while it's great stuff, and I think it's outstanding as it relates to conditions that have happened, it doesn't really include metrics or data that employers honestly care about regarding the health and safety of their workforce in preventing the injuries or preventing the need from their workers having to go and seek care. So every employer that I've worked with, they want the best care for a worker. That makes sense. But what they really want is to prevent the need to have care to begin with. So that kind of goes back to that happy, healthy workforce. And that's what they're really looking for. And that's what I've heard over the years from employers. I want to speak briefly about why. Why is it important to develop strategies, for an employer to develop strategies, and for us as entry point practitioners to address what I would call the cost of pain, and not just the financial cost, but the burden that it presents on employers. I have some statistics here that I'm not going to go through each of these in bullet points, but the bottom line is musculoskeletal conditions continue to be a plague for employers. They continue to be challenging. And while those numbers are coming down over the years, they typically, in most companies that I work with, that's their top injury category that they're seeing: the aches, the pains, the tennis elbow, carpal tunnel, all of those types of things. And we've seen direct costs range anywhere from 40 grand or total costs, which is like your direct and indirect costs combined, but from 40 grand to well over 100,000 per claim that people go through. I think what I find interesting is that many people, whether they relate it to their work or not, about 70% of people, there was a study that was done that say, hey, if I'm having a musculoskeletal issue, their job was a contributing factor to their condition. They're not faulting the employer, but they're saying there's something about what I'm doing here that's contributing to these symptoms. We know that 1 in 2 adults are affected by a musculoskeletal condition, again, leading into hundreds of billions of dollars that are spent annually for treatment. And I could go on and on through this. Musculoskeletal conditions are typically in the top 3 spend categories of an employer's group health premiums and costs that they're spending on workers. We know that the aging workforce continues to expand. And I think even more importantly, this is a key. Employers are really looking to how can I get my employee engaged so that we can experience lower absenteeism, less accidents, less errors, those types of things. And when workers are engaged, that's what happens. But when they're not, it's almost the opposite. There are also a number of epidemiology factors that contribute to MSDs, and there's a lot of information on this slide, but the main point I want to highlight is the individual. So this is more than just ergonomics. We're going to hear about ergonomics today. I believe in ergonomics and in trying to eliminate those risks and all of those aspects that can contribute or lead to injuries, but there's also a lot of individual factors that need to be addressed and can be addressed in particular through a really effective musculoskeletal health program. Lastly, this is my opinion, so I might catch some heat for this, but my experience of 30 plus years of doing this is the workers' comp system and our disability system, while are important, they're pretty dysfunctional. I use this analogy of a roller coaster ride where there's a lot of inertia that builds up to the point of pain, and there's all kinds of activity and chaos, quite honestly, that takes place after that, in particular with like an OSHA recordable injury. So in my mind, what happens a lot of times when the worker leaves the plant or leaves the 4 walls of the company, there's a lot of chaos that can happen. And here's where just the value that we can provide of direct to employer services comes in to change the game, especially as it relates to musculoskeletal health. In a traditional paradigm, if you will, when an employee reports pain, all of these things, whether it becomes an injury or not, OSHA reportable, all of these things happen. And it's a crazy ride. It's a crazy ride for the employer. It's a crazy ride for the employee. And then trying to communicate all the way through all of that. And in that, there's a root cause that contributed to that pain. There's discomfort that's presented. There's pain and dysfunction that the employee is experiencing. And then at the end, those symptoms could lead to a recordable event. I've got the OSHA 300 log up there. This isn't really a topic that's going into detail about all of that, but essentially employers have to report on their safety performance. And like it or not, it's kind of a report card, if you will, that employers use, or a benchmark that's used for employers to establish and show the health and safety performance of a company. In my experience is when that recordable injury happens, all of that other stuff afterwards occurs. The other thing that happens is it leads to, I mentioned cost, it leads to indirect costs related to time away from work. It impacts production. Who's doing the job when the worker's not there? And what burden does that place on the coworkers around the area? The increase in paperwork, who has control of the case and where it's going and how it's being managed? Is it headed in the right direction or is it headed in the wrong direction? Many times it might lead to a legal situation and a legal case. And then again, it just continues to impact these indirect costs related to these injuries. Whether it's work related or not, these things happen. I mentioned also the OSHA 300 log. And I'm going to speak to this because I'm going to talk about using leading indicators as opposed to a lagging indicator. So again, you're talking something that's happened in the past and we're making improvements and changes and strategies around things that have happened in our past performance last year, earlier this year, 2 years ago, those types of things. In many of the companies that I work with, that sample size is small. In fact, I've got probably 15 or 16 companies that we work with, and most didn't even have an OSHA recordable last year. So what do we use then to gather data around the musculoskeletal health of the workforce? So it is an important tool to have. Obviously, it's regulated so that employers have to complete it, but it's not necessarily a reflective tool of what's going on today in the current place. And that's what leads me to early intervention and just talking about that, because an EI program, when it's structured appropriately, is really focusing more on these root causes and at a place of discomfort, not at a place of pain and dysfunction and a recordable injury. We're trying to essentially get, if there's a fire burning and it's in the trash can, we're trying to put it out there. We're not trying to wait for the room to catch on fire. So we're addressing root causes, work factors, home factors, personal health, sort of framing that in the way of like what a worker should start doing or stop doing or keep doing to better manage the symptoms. We like to call it kind of preventing an ache from becoming a pain. And we can do that through a number of different strategies. So OSHA 1904.7, if you're a on-site practitioner and you're going to do or provide early triage or injury prevention services, industrial athlete types of programs to an employer, it's important to know and understand what OSHA allows as first aid intervention as opposed to formal treatment, which we may see in physical therapy or occupational therapy. So here's a list of those things. I'm not going to go through each one in detail, but any one of these services or any one of these interventions here that's on the slide are all considered first aid under the guidance of OSHA's record-keeping guidelines. So this brings me into kind of a key point here that I'm going to go through the rest of the presentation is when we're looking at EI programs, it's very difficult to come up with a documentation system that using kind of an old standard or the standard EMR types of systems. They're inefficient. They don't really apply for the type of services that we see on site, at least that I've experienced. And there's been a need that I identified several years ago to standardize the type of data that we're collecting with any kind of contact that we have within early intervention. There's also a need to generate activity reports for the employers and to use that data to generate meaningful reports, which I think goes back to that value equation. So these are just anytime that we're having a contact or an interaction with an employee's got an ache or a pain or a symptom, my elbow's sore, my wrist is sore, we meet with them and just ask them questions around that. How long has it been going on for? What are the factors you think might be contributing to it? Did anything happen? Did you just wake up with this? Is this something that happened at home? It's all of these types of cases, or all these types of questions that lead to data and the development of data, and how do you capture that and report on that? So we created a database that allows us to enter in all kinds of data points. Again, I'm not going to go through all of these in detail, but some of them, like the employees, like the location or the date of birth or the date of hire, a department, the job that they're in, maybe who their supervisor is, their onset date, when did these symptoms begin? We use a status, are they better, worse, or the same with their symptoms? So we're asking questions not only around their symptoms, but also around sort of the demographics of who is this person, where are they at, what department do they work in, what shift, all of those types of information, again, are data points that we collect. We may collect information around their symptoms, their injury, if you will. Is it personal in nature? Is it something that maybe happened at home that they're clear about? Or is it work related? In our case, if the employer tells us that this is a OSHA recordable work related case, we classify those cases, if you will, as work related. Anything that's in between personal and work related, we describe as potentially work related. We don't really know. Somewhere in that vast chasm stands what we call the PWR types of cases. We look at their injury mechanism, what they may have done at work or at home that contributed to their symptoms. The type of injury, is it a forceful exertion or awkward posture or static position or something else? The body areas that might be affected. And then we also track the intervention information. What did we do to help guide them in recovery and try to quiet down their symptoms and get them on a better path of health? We also, when we discharge our cases, we collect outcomes, and we use, these are just a handful of the outcome categories that we've identified, but we want to know when you enter the EI program and you are discharged from the EI program, what was the outcome? Where did this go? Where did this happen? Well, we find in about, I mean, this is, I think I'm really happy with this, but we see about a 95 to 98% complete resolution rate with the cases that we see with the employers we work with. It wasn't always that way. We had to get the program up and going for a couple of years to accomplish that, but we see significant levels of resolution with our cases, which we're happy to report back to the employer. And I'll speak to that here in the results section. So one of the things I mentioned that provides employers value is give me a summary of what's happening each week within the EI program. And so we use out of the database a CSV a report that the employer can sort and do all kinds of different things with in Excel, but it basically gives basic information about the case. Who all are we seeing? How concerned are we about this case? We use a red, yellow, green categories to identify our levels of concern. Is it personal in nature, meaning the worker clearly has identified this happened at home or out of the workplace? Is it possibly work-related, or is it work-related? The body part, the area, when were they first seen in EI? When was the last encounter date? The status, better, worse, or the same, and then additionally, the frequency or recommendations that we're making around the job itself or case comments. So this is an easy summary report for the employer to get, and it's easy for the safety manager in particular to see who do I need to meet with this week and make sure I'm following up with them, that they're progressing and getting better. We also track what we call ergonomic tasks or activities. So in the course of early intervention, we're not just paying attention to the worker, but we're also talking with them about their job. And there's a lot of ergonomic opportunities that actually get generated within each of these EI cases. So we report on that. We call them tasks, how many were open, how many were completed, how many didn't get complete for whatever reason. In this example here to the right, you'll see how we break it out in basically hierarchy of controls. We use engineering or administrative or PPE controls, but we give specific examples of what were those engineering controls that were identified, how many of those were resolved, how many were abandoned, how many are still outstanding. This is great information because the employer doesn't have to come up with something new. They don't have to go out and do more targeted ergonomic assessments. ergonomics is already happening within the course of early intervention. We also do a case summary roll-up that really provides the employer a nice summary of all the cases that we're seeing, the number of contacts. We call a symptom lag time, which is essentially the time that the employee showed up in the EI program to the time that they're from the time when their symptoms first began. So we have a target of about 2 weeks. We like to see people within 2 weeks of a symptom, but sometimes it's longer than that. And so we track the days in EI, the minimum days, the maximum days, how many cases got resolved, how many cases got referred out, how many remain open, a resolution rate. And here at the bottom, you'll see a cost avoidance estimate that we just say, hey, look, if you had 25% of these 60 potentially work-related cases go on to see medical care, at least 15 of those cases most likely would have become reportable. And it's not what we call a cost savings, it's more of a cost avoidance, but we tie in a return on investment value to that. We also do benchmarking, symptom onset lag time. How does your company and how early workers present with their symptoms compare to the rest of the companies that are in the database? The days in early intervention, even the case severity or OSHA reportability conversion. Employers love benchmarking, and when they can hear how they're doing compared to the rest of the companies, they can see where they need to improve their efforts and, let's say, educating earlier reporting, or they feel like, hey, we're doing a really good job of that. We need to keep doing that and focus our efforts on another area of opportunity for ourselves. We also provide additional information, charts and graphs around injury types and body part areas, injury mechanisms, and department activity that tells us who's engaged in what areas, what supervisors might be engaged with early reporting symptoms. So all of that data, I didn't include this in here, but we can track information around the age of the workers. What should we be implementing for preventative services, for instance, with older workers? What could we be doing with new hires and onboarding processes to get them educated and aware of maybe the EI program or movement screens, even nutritional lifestyle habits, all of that, those value adds come about because of the data that we report on and collect and give back to employers. And so in summary, when you're able to provide data and collect data, how you manage the EI cases and then report back on it, it leads to positive changes in the health and safety performance of the employer. It leads to employee satisfaction because they feel cared for. It has a cultural impact on the workforce, so it becomes more positive and engaged as opposed to a disengaged workforce. And then it can lead to this awareness around prevention and health and other strategies to keep people working healthy and safe, as well as reduce costs. I'm at the end of my presentation. I just want to briefly say that this process has really given me a ton of resources to work with, and looking to use even movement screens, inspiration to continue the goal of promoting optimal health and musculoskeletal health of the workers in the workforce. And I just want to, like, over the years of doing this, the best injury retreat is the one that never happened. And the more that we can do as frontline physical therapists, providers, on-site providers, to fuel that, the healthier the workforce is going to be, and really in the end, it's a win-win-win combination for everyone. So here's my information. I've got references at the end of this as well, and I am gonna stop sharing here and open this up to any questions if I've got, like, I think 2 minutes. Is that right, Chris?
That's about right. That sounds good. So, do we have any questions?
I have one for you, Scott.
Yeah.
Great presentation, by the way. But I was just wondering, I think you said in like 2015 you had a chance to kind of present, or I guess speak with OSHA on
Yes.
just, some of the barriers. I guess what do you, because I mean, I feel like we all understand the limitations on what we can do in the workplace because of that. But what would you say? Do you feel like you guys, OSHA's more wanting to work with us and allow us to continue, I guess, stretch ourselves as far as we can, or do you feel like they fight against us more? I don't know if that's a great question.
No, that's a great question, and I want to be respectful of the time in the group, Garrett. I could go into we've presented on this nationally at conferences and all of that. the simple of it is that OSHA is willing to meet with therapists. And when we first met with them, they were so excited. They had a whole team of physicians and statisticians all there. We were blown away because they're like, we don't really get an opportunity to just meet with 4 different therapists who aren't here for some sort of purpose to build their business. You're just here to help workers stay healthy.
Sure.
And they see that and they responded to that. I think the relationship that at least that we've had working with them and even with the APTA has been very, very positive.
Excellent.
Scott, great presentation. We also have a question from Steve Allison in the chat. Why were the total contracts much greater for the personal health conditions versus the PWR group?
Yeah, I'd have to go back and look. That can vary, and this is the value of data. So when you are able to break out data on personal cases versus potentially work-related cases, understanding, hey, are we getting more engagement on the personal level or more engagement on the potentially work-related level? And then contact-wise can vary. It could just be that some workers are there that week and other workers aren't. So we only count contacts or track them, obviously, when it happened. So there could be a handful of different reasons why, but without tracking the data, this is the key. Without having that in front of you, it's difficult to make decisions or see those trends. So I guess, in God we trust and all others bring data, right? So.
Scott, I had a question too, because when you use that potentially work-related category, is there any issues with the employer liability in that regard for financial issues?
No, that's a great question. When we onboard with like our EI services with an employer client, there's a full day that's engaged into that so that we are establishing clarity and agreement around that. It is just simply a category. It's not any statement of fact. What is a fact is if the employer said, Joe has a work-related injury and he's OSHA recordable. Great, that's work-related. What is a fact is when an employee says, I did this at home, fallen off a ladder and twisted my knee. Can you look at it? The reality of it is, even those personal cases, I don't know about other states, but in Illinois, if work aggravates an existing condition, it can become reportable. So it's just as important to pay attention to those personal cases as it is the potentially work-related cases. And I think bigger is your N. You've got now 50 cases to work with to make decisions around your health and safety parameters that you wouldn't have if you had 0 reportables. What number do we use now? I think that's the real value that EI brings to an employer.
Great, thank you very much. What we'll do is, if any others have questions, we'll hold those till the end when we do the group chat piece, when we all get together and talk about anything that we want to bring up. But great presentation and great start off for our group today.
Great, thank you.